Hello, everyone. My name is Martha Smith, and I'm an obstetrics and gynecology resident at the University of Toronto. The title of my project is Screening for Gonococcal and Chlamydial Infections in the Third Trimester. I would like to acknowledge my co-authors, Dr. Kristen Harris, Dr. Sarah Kivez, Dr. Douglas Campbell, and Dr. Mark Uden. There are significant consequences of neonatal exposure to untreated maternal chlamydia or gonorrhea. One of these risks is ophthalmia neonatorum. Previously, all newborns in Canada were given erythromycin eye ointment as prophylaxis. However, a statement by the Canadian Pediatric Society in 2015 advocated against this practice due to limited evidence on the efficacy of prophylactic agents and risks of newborn eye irritation from the medication. Instead, they suggested relying on prenatal screening for maternal gonorrhea or chlamydia, which is also not a perfect solution. For example, the current Canadian guidelines suggest prenatal screening for gonorrhea and chlamydia once, either in the first trimester or at presentation to care. This may miss infections that occur later in pregnancy. The objective for this study was to look at the incidence rates of gonorrhea and chlamydia in both the first and third trimesters for prenatal patients at St. Michael's Hospital. This is a large urban hospital located in Toronto, Canada. Although there was a policy to give universal eye ointment at the time, the rationale was to determine how many infants might otherwise be at risk of exposure to untreated maternal infection. This was a retrospective chart review of patients who delivered at St. Michael's Hospital between May 2016 and April 2017. At the start of this period, there was a change in practice for all obstetricians that involved administering routine gonorrhea and chlamydia screening in the third trimester, in addition to usual guidelines. A total of 1,512 charts were ultimately reviewed. With regards to screening rates, 74.2% of patients had a screening test during the first trimester. 69.7% of patients had a screening test during the third trimester. 10.7% of patients were never screened during their pregnancy. There was a total of 14 positive tests for either gonorrhea or chlamydia. Of those positive tests, there were 4 in the second trimester. 3 out of 4 of these tests were in patients who presented late to care. The other test was done in a symptomatic patient. In the third trimester, there were 6 positive tests. Again, 3 out of 6 of these tests were in patients presenting late to care. The other 3 positive tests were in patients who had had a prior negative screen in either the first or second trimester. 2 of these patients had none of the traditional risk factors for acquiring an STI. So in summary, there was a few interesting findings that came out of this study. The first is that screening was not perfect, with 10.7% of this population having no STI screening done during pregnancy. If we're relying on screening to detect risks to neonates at the time of delivery, we may not be aware of untreated maternal infections. Secondly, a significant portion, 6 out of 14 of the positive tests, were in patients presenting late to care in the second or third trimester. So this is a population that should definitely be screened once they present. Finally, there were 2 asymptomatic patients who tested positive for chlamydia in the third trimester and had no traditional risk factors for acquiring an STI. Without routine third trimester screening or universal eye ointment, these are neonates who would have been at risk from exposure to untreated maternal infection. This raises the question of when optimal timing is for STI screening during pregnancy to detect risks to neonates at the time of delivery. If we only screen in the first trimester, there's a risk of missing asymptomatic infections that occur later in pregnancy. The options would be to universally screen in the third trimester, which has significant associated costs, or consider moving routine screening closer to the time of delivery. Thank you for listening to my presentation. I look forward to any thoughts or questions that you might have.